In the 19th century, activist Dorothea Dix crusaded for the creation of state hospitals. She wanted to get the mentally ill out of jails and attics and into places of moral treatment. Originally, these were refuges, farms with fresh air. But as the population grew, funding didn't keep up. By the 1940s, state hospitals were warehouses of human misery, overcrowded, filthy, and abusive. Doctors used lobotomies and forced sterilization to manage the population. They became places of social control, not healing. The movie One Flew Over the Cuckoo's Nest solidified the public turn against them. 4 things drove the movement to close the asylums. First, technology. The invention of Thorazine in 1954. Suddenly, psychosis could be treated with a pill. Doctors thought they had a cure. Second, law. The civil rights movement argued that locking people up without a crime was unconstitutional. Third, money. Medicare and Medicaid were passed in 1965, but they included an IMD exclusion. They wouldn't pay for care in mental institutions, only in community hospitals. States wanted to shift the cost to the feds, so they discharged patients. Fourth, ideology. The anti-psychiatry movement argued that mental illness was a myth or a social construct. President Kennedy signed the Community Mental Health Act in 1963. It was the last bill he signed before his assassination. The vision was beautiful. Patients would live in their own homes and go to local community mental health centers, CMHCs, for medication and therapy. The government promised to build 2,000 centers. They only built about 700, and crucial funding for housing and job support never materialized. We closed the back door of the asylum, but didn't open the front door of the clinic. The result was trans-institutionalization. You squeeze a balloon in one place, it bulges in another. We squeezed the hospital census down from 550,000 in 1955 to 30,000 today. Where did the people go? First to the streets, homelessness, and then to prison. When a schizophrenic person off his meds shouts in the street, we used to call a doctor, now we call a cop. The behavior that was once a symptom is now a crime. Disturbing the peace, trespassing. We have effectively criminalized severe mental illness. The legal standard also changed. In O'Connor v. Donaldson, 1975, the Supreme Court ruled that the state cannot constitutionally confine a non-dangerous individual who is capable of surviving safely in freedom. Before this, you could commit someone because they needed treatment. After this, you could only commit them if they were an imminent danger to self or others. This is a very high bar. It means we often have to wait until someone has a gun in their hand or is starving to death before we can legally intervene. This is the rights versus safety conflict again. This legal standard created the revolving door. A patient decompensates, becomes dangerous, gets admitted for 72 hours, gets medicated, stabilizes, is no longer imminent danger, and is discharged to the street. They stop meds, decompensate, and the cycle repeats. Critics call this the right to rot. We have granted the mentally ill the civil liberty to die in a gutter with their boots on. Is this freedom, or is it neglect masquerading as rights? One policy solution is assisted outpatient treatment, AOT, often called Kendra's Law. This allows a judge to order a patient to stay on medication while living in the community. If they stop, they can be picked up and hospitalized. It is a lease on freedom. Proponents argue it stops the revolving door and saves lives. Opponents, civil liberties groups, call it forced drugging and an invasion of privacy in the home. It is the quintessential soft paternalism, coercing you to take meds to keep you free. Another solution is housing first. Traditionally, we told homeless people, get sober, get on meds, and then you earn housing. Housing first flips it. Here is an apartment. Now, let's work on the other stuff. The evidence is overwhelming that this works. It is impossible to stabilize mental health under a bridge. Furthermore, it saves money. A night in supportive housing costs $40. A night in jail costs $200. A night in the ER costs $2,000. The utilitarian argument is clear. Ending homelessness is cheaper than managing it. Recently, bioethicists like Dominic Sisti have argued for the return of the asylum. Not the abusive warehouses of the past, but true sanctuaries, places of long-term care for those who truly cannot survive in the chaotic free market. They argue that for the severely ill, the community is not a place of freedom, it is a place of terror and victimization. We need a third place that is neither a prison nor a park bench. The challenge is, can we build institutions that are safe and humane, or does power always corrupt the walls we build? To conclude, Lesson 4, Deinstitutionalization is a cautionary tale. It shows that removing a bad system, the asylum, without building a good replacement, community care, leads to disaster. We traded medical control for penal control. We learned that liberty without capacity, without housing, without support, is just abandonment. In our final lesson of this module, we will synthesize these themes, reproductive justice, eugenics, and mental health, into a lecture on the current legal battles defining population health.